a wonderful talk, Serge, and we'll transition to really focus on JAK inhibitors as well as the issue of cytopenias in patients with myelofibrosis. Here are my disclosures. So first, as we think about cytopenias in myelofibrosis, there are several aspects I wanted to raise before we really focused on the issue of therapies. First, as we try to think about the burden of having a chronic disease like myelofibrosis or MPNs, there are many factors of which cytopenias are one. Clearly, there's issue of risk of vascular events. There's the impact of cytopenias that can be disease-related, medication-related, as well as related to progression. There is the concern about progression itself. There is the impact or morbidity of splenomegaly. There is the impact of symptoms. And finally, all of this is really occurring not in isolation, but clearly in individuals, our patients, many of whom are older individuals, in which their comorbidities are incredibly important and certainly can have an interplay. So even the ability to tolerate anemia, hemoglobin of 9, might be dramatically different between a 50-year-old patient and an 80-year-old patient. So clearly our comorbidities are relevant. In terms of cytopenias in myelofibrosis, there are various ways to try to get a baseline level. This is one example where we looked at blood counts in a cross-sectional study of symptoms. So it was not just selected for one therapeutic trial. Anemia being by far the most relevant, indeed only probably a quarter of patients with myelofibrosis with a normal hemoglobin, and almost all of those being individuals with post-PV myelofibrosis who have some preserved amount of erythropoiesis. Thrombocytopenia is less common, but present in about a third of individuals, and it's of note this is before widespread use of JAK inhibition. And finally, leukopenia, which really is quite uncommon. So if we contrast it to the other theme of this weekend's meetings, MPN and MDS, the impact of neutropenia, neutropenic infection is quite a bit less, I would say, in myelofibrosis than it is in MDS. Serge had highlighted before how we have had a great interest in understanding the impact of signs and symptoms and need to be weighed and put in context of the other burdens. Now, cytopenias clearly have had an impact on assessment of risk, specifically with myelofibrosis. If we look at the 8 risk factors identified through the DIPSS plus, let's say, framework for assessing risk, 3 of those 8 are related to cytopenias: thrombocytopenia, anemia, and really an additional level of risk identified if you are red cell transfusion dependent. Now, from my end, as I think about cytopenias, I think there's a few different constructs to consider. First, as I'm managing a patient over time, are cytopenias disease-related? Sometimes the easiest to say before therapy has been initiated. And is that because of splenomegaly? Is that because of inadequate production in the marrow? Is that because of ineffective hematopoiesis or splenic sequestration? Or the issue of drug-emergent cytopenias. The counts are at this level, we begin a therapy, the counts decrease that much further. As we think about trying to improve cytopenias, again, there are many contributors. If an agent is active improving red cells or platelets, is that a direct efficacy in terms of production, i.e. it improves the bone marrow microenvironment, there's literally increased erythropoiesis? Or is there really less of a secondary effect, let's say, with splenic sequestration? You shrink the spleen, and it has a beneficial impact on cytopenias. So again, these are very complicated constructs in terms of both contributors to cytopenias as well as assessing their improvement. Now, as we think about our response criteria, which are utilized by both the ELN and the IWG-MRT, as we think about cytopenias, near normalization of the counts are prerequisites of achieving a complete response. It's not only about cytopenias, but they clearly are relevant. They remain relevant in partial response. And for clinical improvement in the arena of myelofibrosis, there's both criteria for improvement of becoming transfusion independent as well as having an improvement in the non-transfusion dependent individual by an improvement of 2 grams per deciliter or more. Now, how do we treat cytopenias in these patients? Well, frequently, as Serge or I or our other colleagues here in the audience receive emails or inquiries about difficult patients, it is not infrequent that difficult cytopenias are the origin of those problems. Now, prior to JAK inhibitors, we have tested many agents trying to improve cytopenias. And there are several things that have some activity, but as a theme, 1, there are none that are approved for this indication. 2, they mainly have modest amounts of activity in typically 30% of patients or less. 3, there are rare individuals that have had great responses to any one of these, let's say, toolkit of therapies. ESAs, they can be active with all the caveats in MDS, and in my experience have been particularly helpful in those individuals who really have renal insufficiency as well and have that as a contributor to their anemia. The IMiDs have some activity. They all have some drawbacks, and we'll talk about the phase 3 study in pomalidomide in a moment. And finally, androgens do have some activity. Probably in part, there's a fair number of these individuals as we age are probably hypogonadal as they're going along as well. And individuals that really are hypogonadal probably benefit the most. Now, in terms of the IMiDs, they've all had some activity, including thalidomide itself. Pomalidomide, in theory, was of great interest because it had, at least in vitro, the greatest pro-erythroid activity. Phase 1 and phase 2 studies, of which many of us here in the audience participated, showed that there were definite responders, but that the responders still were in less than a third of patients. This is a cumulative analysis of our Mayo Clinic experience with about a 17% response rate. A global phase 3 was undertaken, randomized without a crossover, pomalidomide versus placebo, in individuals who were very transfusion dependent. And this is relevant, and perhaps we selected out those individuals with the most difficult disease. The study was a negative study with response rates, again, about what we had seen from the earlier studies. What was unexpected on this study was a surprisingly high improvement rate in the placebo arm. And this may be a reflection of discontinuation of other therapies to then enroll in the study. There were differences in both time and duration of response. So we do think that there really was activity of pomalidomide versus the placebo, but certainly not enough to have justified an indication. Subset analysis were done to try to find, are there subsets of individuals that seem to respond more? Nothing that was statistically significant, but again, suggesting those individuals who were not as transfusion dependent might have had benefit. It does raise the question, if we had included individuals who were not transfusion dependent, let's say a stable hemoglobin of 9, would it have been easier to see a response? I believe that that may have been the case. Now, what about ruxolitinib and cytopenias? Let me give you an example of a case. 72-year-old, highly symptomatic, spleen not particularly enlarged in this individual, borderline significant anemia, 10-2, white count 14, platelets 180, trisomy 8, primary myelofibrosis. This individual has intermediate 2 risk disease, but is flirting with the other risk factors. He's 10-2 versus 10. Again, that's the limitation of continuous variables as cutoffs for risk. In terms of burden, clearly symptomatic. Individuals begun on ruxolitinib at 15 milligrams twice a day. and has been the experience with others, we'll show you in a moment, he has a definite drop in his red cell count with that 15 milligrams twice a day dose. Now, over time, we've learned several things from our long-term analysis. The 3-year data is pretty clear. The platelets can drop initially with therapy, but they tend to stabilize, and the red cell count can drop with a clear nadir, but tends to have some amount of rebound. Does not tend to go above the baseline level, and improvements in baseline anemia are not common. We've learned over time that the COMFORT studies, which were designed in particular to identify the benefit of reduction of splenomegaly within that 24-week period, really was very front-loaded in terms of dose. Over time, I think we have learned some patience with dosing as well as lower dosing. Our long-term study that I presented for our team at ASCO did demonstrate very similar sort of experiences, now with longer periods of response, the platelets, that initial impact, but then really stabilization, which is relevant because at first there was a great concern, if you drop from 300 to 150, does that mean the patient's going to need a platelet transfusion by next week? And the reality is that that was not the case. They drop from 300 to 150 fairly rapidly, but then they tend to stay at 150, or they go from 150 to 90. But as opposed to other more purely myelosuppressive agents, that does not tend to be a continued decrease all the way down to marked thrombocytopenia. The experience with anemia, again, similar. An initial drop, improvement over time. So in this individual, as was the experience after ruxolitinib was approved, hemoglobin went from 10-2, and now they're 8-2, and they've had a couple transfusions. White count is less, platelets less, symptoms are better. The dose is decreased to 10 milligrams twice a day, which for some individuals tends to be a better fit. And with stabilizing at that dose, the hemoglobin is now recovered some to 9.6, and the other parameters are looking favorable. So I think we've learned quite a bit in terms of optimizing dose to try to decrease drug-emergent cytopenias in myelofibrosis with ruxolitinib. It's not removed it altogether, but it has had some impact. My guidance in terms of dosing with ruxolitinib in myelofibrosis, one, I think over time there's a difference between the initial dose and the long-term dose. Over time, I do think the ability or lack of ability to give an adequate dose to reduce splenomegaly is relevant, and that it's been found that if we are at sustained levels of less than 10 twice a day, we probably have symptomatic benefit, but we may have less efficacy in terms of splenomegaly or survival. So I'm fine starting them lower, but I do try to increase the dose. Now, what about thrombocytopenia? Nice study done by Alessandro, where they looked at 2 different strata of patients with baseline thrombocytopenia, starting them at doses that were identified in prior studies to be safe, 5 twice a day, with the question, can we increase the dose over time to reach those other endpoints? And the answer was yes. In the stratum with a platelet count of 75 to 100, they were able to reach safely 15 twice a day over time. Not immediately. Time is a factor. Second, in the group with even a lower platelet count, they did achieve 10 twice a day. With this, they saw efficacy in terms of improvements in splenomegaly and improvement in symptoms that seem on the surface to be relatively equivalent to the COMFORT studies. This just highlighting in terms of long-term improvements. Again, as we look at symptom response, again, there is clearly a difference between being at 10 twice a day and above in terms of symptom response as well as likely improvements in survival. In terms of thrombocytopenia, same sort of discussion. We can start people at a low level, but we should try to increase that dose over time. Now, what about new JAK inhibitors? Well, I won't belabor this point because Rami Kamraji is going to be giving a more in-depth discussion on this later, but I'd highlight just a couple things at a high level. First, pacritinib, 2 different phase 3 studies. This agent, which in earlier studies was able to be given with efficacy for improvements in splenomegaly and symptoms in individuals with marked thrombocytopenia. We presented this at last ASCO and demonstrated ability to improve symptoms in individuals with marked thrombocytopenia, which is differentiated than the current opportunities that we have, as well as improvement in splenomegaly. And in individuals, we could see improvements in the platelet count as well as red cell transfusion dependence. We've speculated on mechanisms for this, and there's a paper that is in press that has identified a impact on the kinome by pacritinib, which may be responsible for some of these differential effects, including looking at the kinase IRAK1. Now, currently, pacritinib, because of long-term analysis, is on a clinical hold, looking at issues of morbidity and mortality in this trial. In part, we've enrolled patients with very advanced disease and feel that that potentially may be a factor or a confounder. Rami undoubtedly will be discussing this more in his presentation. Next, I would highlight momelotinib, currently in phase 3 studies, one that is fully accrued, momelotinib versus ruxolitinib as upfront therapy, trying to seek superiority for anemia and non-inferiority for splenomegaly and symptoms. In parallel, there is a second-line study which is ongoing. Third, earlier in development, but NS018 being tested as second-line therapy, trying to have also an impact on cytopenias. Where might these additional JAK inhibitors fit? Potentially as front line in patients with marked cytopenias might be a discussion, as well as second-line studies are both ongoing and as well as of interest. With pacritinib, Dr. Rostovchuk has helped lead the PERSIST-2 study, of which we hope to identify information from that study in the near future. Now, what about combinations? Combinations have been, the experience has been mixed. Our group led a combination study of ruxolitinib with danazol, less drug-emergent cytopenias, and some improvement in baseline cytopenias. I'll show you that data in a moment. Not overwhelming, but not negative either, and danazol can be frequently fairly inexpensive and safe to give. Ruxolitinib and pomalidomide, difficult to say that there is a significant level of activity here. Ruxolitinib and lenalidomide, Dr. Rostovchuk led this study. Difficult for patients to tolerate both of these agents, so it's hard to say, but with the myelosuppressive aspects of lenalidomide, no improvements were really seen. Ruxolitinib and thalidomide, we've been using in some patients off study, but really there's not been formal trial data and not enough data to really know whether this is beneficial. It is always possible that the IMiD mechanism of action on the marrow may in fact even potentially be inhibited by JAK inhibition, so I think we'll need to wait and see. With the danazol study, what we saw was if we try to think about response in a slightly different way, less drug-emergent cytopenias or improvement in baseline cytopenias, we did see a combination of both that would suggest perhaps less drug-emergent cytopenias when using concurrent with a JAK inhibitor. Further studies, I think, will be forthcoming. So I'd like to conclude by saying that anemia, even much more common than thrombocytopenia, really contribute to the disease burden and are adverse prognostically at baseline. There are agents that have some activity, but really overall their benefit is fairly modest. Adjustments of ruxolitinib dosing definitely does have an impact on drug-emergent cytopenias. However, the patient that enters therapy with ruxolitinib with baseline cytopenias, we usually do not expect significant improvements. And finally, new drugs that will be highlighted more in this afternoon session are hoping to try to help make a further impact in this area, both with other JAK inhibitors such as pacritinib and momelotinib, as well as other new agents such as PRM151 and imidostat. Now with that, I'd conclude my talk.